Hi, good evening, guys. I'm so sorry. I'm really sorry that there was a mistake in Zoom application, so it was not getting connected. It was not getting connected to YouTube. So immediately we have resolved this problem, and we took some time, 15 minutes. So I apologize for that. Okay, guys. So without delaying any time, we will start. Right? I'm so sorry. Today was some mistake. Good evening, guys. Uh, So let's start. You guys ready? I'll share my Zoom screen. So we will just start the streaming. Yeah. Is it visible? Okay, so I hope it's visible to all of you guys. Right. One sec, I think. Okay. Yeah. So, guys, a small announcement before starting. So, we are coming up with a conference, with the big conference, first time ever in India on medication therapy management, right? So this conference is going to be on 19th and 20th December 2020, third weekend of the December, 19th and 20th December of 2020, and it will be virtual, and we are organizing this in collaboration with the Indian Pharmaceutical Association IPA Central, and then World Youth Heart Federation WIHF, and ACPI Association of Community Pharmacists of India. So these three are our major partners. These three are our major organizing associations with whom we are conducting this conference. And the theme of the conference is revolutionizing medical outcomes in India, and this is on the medication therapy management, right? So where we are calling more than eight, when there are more than 8+ keynote sessions from eminent national and international speakers, and this is one of the unique conference. Can you please mic mics, please take care of the mics, guys. Okay, mics here, take care. Right. Okay, then this conference has eminent national and international speakers. We have diverse subtopics. We have diverse healthcare domains for the delegates. We are including pharmacy, medical, dental, and any life science candidate who was interested in medical therapy management and who wants to present their cases, thesis, or any kind of research. They can participate in this. So we have very diverse topics, like from the importance, significance. It is very specific actually on MTM, but the research presentations are diverse. From as I will say, I'll show you in the next slide. The topics we are covering is a few specific diseases like oncology, diabetes mellitus, respiratory disease, cardiology, and infectious diseases, right? And we are talking about the current scenarios of MTM in India. We are talking about the future perspectives and challenges in implementing MTM and the importance and significance of the MTM. So here we have the registration link, and the last date of registration is December 10th, 2020. So this is going to be India's one of the best and one of the biggest conference because we have the great partners, big partners. So guys, all the students, I will say all the students from all the category of our healthcare fraternity are able to join us and able to send their abstract. All the clinical cases what pharmacy people or medical students they present in their classes or in their fifth year or sixth year or in their fourth year, whatever they present the cases, clinical cases, anyone is allowed to present their cases in this conference as well, in the soft format or in any format you have the case, you can come up with the case, you will submit your case, and you will get a chance to present. MTM therapeutic studies, if you have any related any study related to MTM, like healthcare resource utilization or medication management or medication related errors or medication utilization, you can submit your abstracts under MTM therapeutic studies category. Then there are the chance to there's a chance to submit your 3 minutes video on any kind of intervention challenges and implementation of MTM. You can prepare your 3 minutes video and submit through the submission link. And then general research studies, also there is another category called general research study, where you can submit any kind of healthcare related study like epidemiological, pharmacovigilance, PKPD, basic science, or you can submit your review articles or meta analysis as well. So there are except these abstract submissions, science presentations and everything, there are many activities like there are MTM quizzes. So there are 3 or 4 types of quizzes, there are 3 to 4 types of another events during the conference. So you can just go through the link, you will get the types of submission and types of activities which you are interested in, and you can fill the form and submit. So, and all the certificate, all the participants, presenter and winners will get their respective certificates and the participation certificate. And there are multiple many types of awards, including internship, including 5,000 rupees and for to avail the courses, free courses, and many things, many awards are there, many awards are there for the students who are participating in this. And the most important part, that we have more than 25 partnering institute, 25 premium institutes from India. Many are pharmacy colleges, medical colleges, nursing colleges. We are collaborating with the University of Florida very soon, and this conference is going to be really big. From as a, for an example, in India we have already partnered with the Sultanul Uloom College of Pharmacy, Hyderabad. We have Pune College of Pharmacy, Bharatiya Vidyapeeth Deemed University, Pune. We have Sarda Vilas College of Pharmacy, Mysore. We have PSIT, Kanpur. We have DY Patil Institute of Pharmaceutical Research and Sciences and Research, Pune, Maharashtra. We have Dayanand Sagar University. We have Assam Downtown University. We have St. Paul's College of Pharmacy, KLE, and Integral University, Lucknow. These are just few numbers. Many more are there, which we are launching in our full brochure. So you can contact us. You can fill the abstract form if you want to submit your abstract, and you can register the conference. So now, very important information, guys. Very important, that I am so sorry to inform you that today Dr. Sudhakar Rao was supposed to take class. Our Dr. Sudhakar Rao, Associate Professor Cardiology from Kasturba Medical College, Manipal. He was supposed to take your class on beta blockers, as this was in the schedule, beta blockers. But due to some health problems, as he got COVID positive day for yesterday, and he's admitted in the hospital right now. So I have to take this class on short notice, very short notice. I have to take this class. So rather than beta blockers, I chose to go for anatomy of heart, because it was his topic, and he will be taking this topic maybe shortly in December 2nd week or December 3rd week. So today, because I did not want to cancel the class, so I came up with the anatomy of heart, as this class I have taken somewhere else, frankly. So, but definitely you will not be bored. I will make it as simple as anything for you guys. Anatomy of heart, right, guys? So let's start. I'm Dr. Ajit Singh, and we are going to talk about anatomy of heart under the course of basics of cardiac pharmacology. So let's start. Today, what we are going to study in this class, heart and carotid system, and heart about the heart valves, about the septal defects. What are the septal defects? Related to heart valves, and what are the cardiac muscles? What kind of cardiac muscles we have in our heart, and what are the echocardiogram says or electrocardiogram says, and how to know about the conduction system and how it works, and we will also talk about the lymphatic system in the heart, right? In the body. So let's go. Yeah. So first slide is about the heart. As everyone know the relevant structure. Really, everyone know the structure of heart, and they know that there are four chambers in the heart. We know that, but when we go to the deep thing, when we go to the deep anatomy or deep access of the heart, that what's there in the heart, and how it works, and what kind of muscles are there, and what kind of valves are there, then we have to know properly. Then we have to know properly how. So let's check first. Let's check the blood flow. Let's check the blood flow, how it comes. So there are two kind of vessels. One is arteries, one is veins. So arteries are what? Arteries are carrying the blood from the heart to the body parts, and veins are collecting the blood back to the heart from the body parts. Got it, guys? Arteries are distributing the blood from the heart to the body parts, different body parts, but veins are carrying the blood back to the heart, right, for the purification in the lungs. But here is a difference, little bit difference in the arteries and veins when it comes to the pulmonary veins and arteries. Because in the pulmonary veins, in the pulmonary system, pulmonary veins work actually as as artery, and pulmonary arteries works as the veins, because it carries the impure blood. So this common difference in arteries and veins are like, first of all, arteries are carrying the blood to the body parts and veins are collecting back. But there is another difference, that arteries are having the pure blood, oxygenated blood, which is coming from the heart to the body parts, and veins are having the deoxygenated blood or the impure blood, which has the different components, different foreign particles, and different I mean that deoxygenated blood, carbon dioxide is there, CO2 is there in the blood, right? And this is going to your heart, this is going to your heart, and through the heart it will go to the lungs, right? So let's check the blood flow. As we can see here, there is superior vena cava. You can follow my cursor, superior vena cava, and then inferior vena cava, right here. You can see the inferior vena cava downside here. So these are the major arteries, these are the major arteries which are collecting the blood from the small arteries, from the peripheral arteries, from the systemic artery, sorry, like systemic veins, and peripheral veins, and these one sec. Okay, so here they are collecting the blood from the different small veins, and then the major veins, inferior vena cava and superior vena cava, are bringing that blood back to heart. So from the superior vena cava and inferior vena cava, where these two major veins open, these major veins open in your right atrium, right? Like here, see, this blood is coming from a vena cava to the right atrium. Now from the right atrium, this blood will go to the right ventricle, right? The blood will go to right ventricle, and here there is a valve. What is the role of valve? Always prevent the backflow of the blood from right, like if it is between the right atrium and right ventricle, it will stop the backflow of blood from the right ventricle to right atrium, right, guys? It should not come back, the blood should not come back. So blood will go to right atrium to right ventricle now, and after right ventricle, it will not go to the left system of the heart. It will directly go to the lungs through the pulmonary arteries. Here, pulmonary arteries. Why arteries? Because these are carrying the blood from the heart, away from the heart, right? because these are carrying the blood away from the heart. That's why we are calling them artery. But here in the pulmonary arteries, this is not the pure blood, this is impure blood, this is deoxygenated blood, right guys? So now this blood will go to lungs. This blood will go to lungs from the pulmonary artery, I mean from the heart through the pulmonary arteries. Then in the lungs, through the lungs, it will get purified, it will be oxygenated, and carbon dioxide will be eliminated, and few foreign particles will be eliminated. Then again, that blood from the lungs, it will come back to heart through the pulmonary veins. Why it is calling, why we are calling veins when they are carrying the pure blood? Because these are carrying the blood back to heart. uh, doesn't matter from where, but these are carrying the blood, or what kind of blood doesn't matter, but these are carrying back. That's why we are calling them vein. So pulmonary veins are carrying pure blood from the lungs to heart, as we can see here. And this blood is not going back from it came. Now it is going to the left atrium. These all veins from the right lung and left lung are opening in the left atrium. Then from the left atrium, this blood will go to left ventricle. This blood will go to left ventricle here. See, follow my cursor, left ventricle. And between left atrium and left ventricle, there is the valve, and the valve is called aortic valve. Here, see, aortic valve. This valve is called aortic. Sorry, this valve is called mitral valve, right? Mitral valve, right? Left atrioventricular valve, left atrioventricular valve between atrium and ventricle. So it is called atrioventricular valve or mitral valve, right? Here, the similar in right side, it is called right atrioventricular right AV valve or tricuspid valve. Why it is called tricuspid valve? Because there are three flaps, three leaflets in the valve, right? Here in the mitral valve, there are two leaflets, right? So now blood is there in the left ventricle finally. So from the left ventricle is the kind of largest part, kind of strongest part, because all the blood flow from the heart, all the blood pumping system, left ventricular is involved in the pumping system, all the pumping system. So it will throw the blood from the heart to the body. So from the left ventricular, it will go to the arteries. It will go to the arteries. Which artery? Aorta. Aorta is like the we can say the bigger size of arteries, the largest size of arteries. So these are taking the blood from the heart. See here. And then this arteries, the aorta is distributing the blood from the for the different systems in the heart, like brachiocephalic arteries are taking blood to brain, and this left common carotid artery is also taking it to the different regions of brain. And then it is coming down, and it is distributing to every part of the body, right guys? So this is the simple anatomy of heart. And then now rest I mean another
ఎంపీ
one.
వచ్చిందా?
uh, Please, Mike.
జగనన్న అపాయింట్మెంట్ కష్టమైంది.
Mike. Okay. So other than this, let's come to the valves. So as I was telling, between right atrium and right ventricle, there is tricuspid valve or right atrioventricular valve. And then in the left side, between left atrium and left ventricle, there is a mitral valve. And now guys, between veins pulmonary veins and right ventricle here, when this blood is flowing from the right ventricle to pulmonary veins, it should not come back, it should not flow back. So there is pulmonary valve, there is pulmonary valve, right? And then another valve is here, when the left ventricle is throwing the blood or pumping the blood from left ventricle, pumping the blood to the ascending aorta or descending aorta, right? So here is the valve called aortic valve, because it is stopping or preventing the backflow of the blood from aorta to the left ventricle. Got it, guys? And then after this, let's come to the next slide. Now, what is the carotid system of the what is the carotid system? So carotid system is the system which carries the blood or which supply the blood to the brain. So as we can see here, this is aorta, and there are the common carotid arteries, this in between, which is supplying the blood to the different regions of brain through different small arteries, through different branches of arteries, like middle cerebral artery, or posterior cerebral artery, or basilar artery, or this anterior cerebral artery. So anterior cerebral artery is providing blood to the frontal area, and middle cerebral artery is supplying the blood to middle region of the brain, and the posterior is to the back side of the brain. And here the internal carotid artery, this internal carotid artery is also supplying the blood to your blood and nutrition to your eyes, here. See, this is supplying the bloods to your eyes as well. So just extracurricular point here, when when this stroke happens, so in case of stroke, this carotid artery usually get blocked. This carotid artery get blocked, right? This the plaque persist here in this carotid artery when the stroke, whenever the stroke happens. In case of a stroke, this carotid artery get blocked, right? So that's why the symptoms are related to neurology, or related to brain, right? Paralysis, or blurred vision, slurred speech. So that's why, because this the supply of the oxygen is not sufficient to the brain in case of stroke. So this artery get blocked, right? Okay, so now heart valves. As we were talking about the heart valves, simple again. Let's. Mhm. Sorry, what is this? Okay, yeah. So let's check here. As I was talking about, from the vena cava entry, all the veins, the blood will come to right atrium. Now, from the right atrium, it will go to right ventricle. So this is tricuspid valve. As I was telling, tricuspid or right AV valve, right? And here, from the right ventricle, the blood, impure blood, through the pulmonary valve. Through the pulmonary valve, it will go to pulmonary artery and lungs. From the lungs, it will come to left atrium, and from left atrium, through the mitral valve. Through the mitral valve, it will come to the left ventricle, and uh, from the left ventricle, through the aortic valve. Through the aortic valve, it will go to the aorta, and aorta will supply the blood to the different parts of the body. Now, what are the diseases we usually see related to the uh, valvular, what are related to our heart valves? So we call them valvular heart disease because these are related to our heart valves, right? These are related to our heart valves. So what are the diseases? There are three kind of problems. What actually appears with our heart. So these three problems are: one is stenosis, one is prolapse, and one is regurgitation. Okay, so what is stenosis? Valvular stenosis, or any stenosis. Stenosis is when the valve opening becomes narrow and restricts the blood flow. Stenosis is actually a kind of blockage, or kind of a clot formation in the valve. Kind of clot formation in the valve. So in that case, it will or narrow the opening, and it will restrict the blood flow to the valve. Stenosis, right? And then it will come to the prolapse. Prolapse is nothing but it is when a valve slips out of the place, and the valve flaps do not close properly, right? In that case, the valve flaps, as I was telling, in mitral valve there are two flaps, in tricuspid valve there are three flaps. So these flaps slips from the place. So in that case, these are not closing properly. So what will happen if they're not closing properly? What will happen? Due to this, the backflow will be there. Blood backflow will be there. So in case when our right atrium is supplying to the right ventricle, so blood will come back. So proper sufficient amount will not pass on to the next step, to the next chamber. In that case, what happens, like sometimes when your pure blood is going to body parts, it will not be going sufficient, because from the aorta it may be coming back to left ventricle, right? So this kind of problems can decrease your sufficient supply to the different parts, or sufficient supply, sufficient purification, because when this sufficient blood will not go to your lungs from the right ventricle, it will be a problem, correct? So stenosis and prolapse. What is regurgitation? Regurgitation is nothing but it is the leakage of the valve. Leakage of the valve, maybe due to prolapse or maybe due to some other reasons, or due to some other problems, but it is called as the leakage of your valve, right? Leakage of your valve. So what are the problems related to that? Usually valve related problems are congenital. Congenital means what? These are from the birth. These are from the birth. So congenital valve disease are it could be in the different shape, it could be in the different valves also. So when a heart valve being the wrong size or the wrong shape, or its valve flap are not being properly attached to the heart or not closing properly, so when the babies after the delivery of the baby, when we come to know, or even nowadays we have the facilities of fetal echoes. So in that case, we come to know that baby has some problem. Baby's valve are not developed properly. These are not in the proper shape. These are not in the proper size. So or these are not opening or closing properly. So these conditions in childs, in children, are called congenital heart disease, or valvular heart disease, right? So it could be bicuspid aortic valve disease. Instead of a normal three leaflets, instead of a normal three leaflets, aortic valves has only two leaflets. Only two leaflets. As I was telling, between right atrium and right ventricular, there is aortic valve, right? There is aortic valve, and that is tricuspid. There are three leaflets in that valve. But what happens in some kids, in some infants or babies, they developed only two leaflets. There are only two leaflets, or there are no and there are no three leaflets. So opening and closing is tough in that case, right? And there is a leakage, or there are some other problems, regurgitation kind of problems, right? Then some other disease is called as Marfan syndrome. Marfan syndrome is nothing but it is a genetic disorder which affect the body's connective tissues of the valve, heart valve. When the connective tissues are not correct, when the connective tissues are not well developed in the during the fetal development, what happens? Your heart valves are not properly developed. So that syndrome can cause multiple problems, like repeated endocarditis, or regurgitation, or maybe there are the high chances of prolapse. And since symptoms also occur in the infants or babies. So in that case, we have to check all the aspects when baby is taking birth or after the delivery. We should go for infant echocardiography. Echocardiography, I will suggest every baby who is taking birth should undergo echocardiography before after the birth. Not immediately, but maybe in few days they should go, but they should go under echocardiography. They should check, because nowadays there are many things which can affect the baby's development, which can affect the infant's development or fetal development, which can affect the leaflets, or which can affect the heart size, which can cause the cardiomegaly, or which can create the heart failure in the babies. So there is the solution for everything, or the diagnosis for everything is echo. You have to go through the echo. So then there are two causes. There are certain causes for the valvular heart diseases. One is acquired causes. Acquired causes could be rheumatic fever, okay, inflammatory problems, inflammatory fever, rheumatic fever. It could be infective bacterial endocarditis. It could be viral problems. It could be the radiation therapy, due to the radiation therapy which was taken by the mother, or for any disease or any problem, or maybe she underwent so many CT scans, or so many MRIs. So due to that radiation therapy or radiation exposure also, baby can get valvular heart diseases, right? And sometimes these problems are found in the aged peoples also. That could be due to any reason of like rheumatic fever, or any infective endocarditis, bacterial or viral, or any radiation therapy, or due to their increased age. And increased age also, these problems are common, if not in the infants or if not in the babies, right? Then there are certain other causes for valvular heart diseases, and these causes are like coronary artery disease, when the patients have some infraction in any coronary artery, so that blood supply will be inappropriate, and the oxygen supply will be inappropriate in that region, so it also can cause the valvular problems due to that sudden infarction. And then cardiomyopathies are nothing but the increased size of the heart or increased size of the heart valve, and the thickness of the thickness increased thickness of the heart wall, and thickness of the endocardium, or that increases in that case, right? And there are certain metabolic disorders which can cause valvular heart diseases and cardiac tumors, and there are certain drugs which are totally prohibited in cardiac conditions, and which can really cause when they are used for long term, which can cause the valvular heart disease as well. So I'll go to the next slide. Yeah. So now let's come to the cardiac septum. Cardiac septum is what? Cardiac septum is nothing but it is a wall between two chambers. It is a wall between two chambers, like as we can see in the left side picture here. Can you see this? So this septum is called atrial septum. Atrial septum, because this is differentiating both the atriums. It is between both the atriums. It is separating both the atriums, right atrium and left atrium, so it is called atrial septum, right? Atrial septum. But when something happens, when some defect is there, it is whether it is not well developed, whether it is leaking, or whether there is some problem, so these conditions are called as septum or septal defects. So that as we can see in this picture, it is between the atriums only. It is between the atriums. So that's why we call it atrial septal defect. Or usually we know these septal defects as hole in the heart, right, guys? So these are the concept behind hole in the heart. If anyone has hole in the heart, that means they must have the atrial septal defect or ventricular septal defect. Ventricular septal defect, right, guys? So or they may have some other kind of defect also, but that usually found in childs only, PDA. I'll tell you about that. So this defect is uh, called atrial septal defect. And then when the same defect or the same leakage or the same development is not proper in here in the ventricular septal is between two ventricles, like right ventricular and left ventricular, right? Left ventricle. So if this is not developed properly, or if there is some leakage, or if there is some hole, or if there is some connection between two ventricles, it is called ventricular septal defect, right? Ventricular septal defect. Now what is the disadvantages? What is the problem if these if these defects are here? See, as you can see here in the first picture, if there is a septal defect between right atrium and left atrium, see, as you can see here, the blood is going from the left atrium to the right atrium, and blood is going from the right atrium to the left atrium, right? Because there is opening, because there is an opening, right? So what happens, because right atrium has the impure blood, blue color is impure blood, and the red color is pure blood, because it is coming from the lungs, and this is coming from the veins of the body. So when there is a septal defect, atrial septal defect, this blood get impaired. This blood get impaired, and this can create multiple problems. Like what? When left atrium has the impure blood, actually it's supposed to be the pure blood, but when it has the impure blood will only go to the left left ventricle, right here, and then impure blood will only go to your arteries. And when there is impure blood, means that blood contains so many foreign particles. It contains deoxygenated blood as well, so oxygen carrying capacity will decrease, so it will cause you the respiratory related problems, or it will cause you the breathlessness, or it will cause you the fatigue, or there are so many other things, we call it like hypoxia, and all conditions will appear in this case. And patient or the kid or any kind of whoever is the age, or whatever is the age or population, they will face many problems. Their exercise capacity will not be well and good, because they have the less oxygen supply or insufficient oxygen supply in the body parts, to the body parts. Right, guys? So similarly here, in the ventricular septal defect, if there is a connection between left and right ventricle, again the pure blood and impure blood will get mixed, and the whole this blood will go to the your body. Impure blood will reach to your body through your aorta and from the left ventricle. So it will again create the problem, because it is impure, because it has the foreign particles in that. Then there is something called patent ductus arteriosus. What is this? PDA is the defect, similar kind of leakage or similar kind of hole between aorta and pulmonary artery. See here, aorta and pulmonary artery. So what happens when pulmonary artery contains, or pulmonary artery carries the impure blood, and aorta has the pure blood? So in that case, it will get mixed directly. It will get mixed, and the problems will be similar to ASD or VSD. So these three things are called, majorly these ASD and VSDs are called the hole in your heart. These are not exactly dangerous, because nowadays we have all the facilities with us. We have all the facilities of closing these holes. We have all the facilities related to the closer, like we have devices, we have clips, we have bandages, the different bandages, of course these are costly, but there are the treatment options for these kind of heart problems, these kind of ASD or VSD or cardiac septal related defects. So we should not be worried about that. Usually, one more thing, very interesting fact I want to tell you guys, because you should know these things, because you are the beginners, and most of you are the beginners, so you should know that if you find some baby, or if you find any family related who has that kind of problems, ventricular septal defect or ASD, if it is not complicated, you can tell them they need not to worry, because some babies have that defect. If they are premature, or if they have some problem, they can they will have this hole in their heart. But usually in case of BSD or in case of ASD also, we give some time, 8 months or 10 months or maybe 1 year, or sometimes we wait for 2 years after the birth. So it will automatically fill, this gap is automatically filled, right? So in that case, it's not need it's not need not to worry, right? Let's go to the next slide. Septal defect. So I was telling you, atrial septal defect is the hole in wall between two upper chambers of your heart. Ventricular septal defect is between two lower chambers. And patent ductus arteriosus (PDA) is persistent opening between two major blood vessels, like one is aorta and one is your pulmonary artery. So cardiac muscles, what are the cardiac muscles? Cardiac muscles are, actually in the body, there are three types of muscles. One is cardiac muscles, one is skeletal muscle, and one is smooth cell muscles. So cardiac muscles are, much simpler than others, because these have the very simple structure. These have, the outer cell, and these have the simple as the other common muscles have. They have the sarcolemma, they have the nucleus, they have the mitochondria, they have the T tubules, they have the sarcoplasmic reticulum inside the muscle itself, right? And they have some intercalated discs, and yeah, that's all. In the muscles, these are very simple. Cardiac muscles are as simple as you have your very simple muscle in your body. Other muscles are very complex, like your abs complex, like your abs muscles, or muscles in your larynx and pharynx, muscles in your movement hips. Those muscles are very complicated, but cardiac muscles are very simple. These have limited fibers, or limited kind of components, mitochondria and T tubule, sarcoplasmic reticulum, and nucleus. Everyone knows nucleus is the center of the muscle or something. So right, now let's come to the cardiac conduction system. I'm taking just basics of anatomy, guys. Cardiac conduction system. What is cardiac conduction system? So there are, just you have to understand, like heart is your home. Heart is your flat, right, in your body. There are every home or every house has two symptoms, sorry, two type of systems. Every heart has two systems similar to your house, right? One is water system, as there are the pipelines. Similarly, in the heart, there are the pipelines which we call vessels, or then again veins or arteries. And then your house has the electricity system. So heart also has the conduction system. So it is similar to your house, and these both are separate entities. These both are separate entities. These are not common. These are not the simple things, right? So in that case, you have to take care of the both. If anything get imbalanced or get affected or get infected or get infracted, in that case you will be in the problem, right? So you have to take care of all. Now, as we have discussed about the blood flow, as we have discussed about the water supply system, now let's talk about the electricity system in the heart. So this electricity system, or call, if we say the cardiac conduction system, is, let's see here, follow my cursor. It starts from this point. It starts from this point. This point is called as sinoatrial node. This point, sinoatrial node, as you can see here at the first point, the sinoatrial node, or this is also called as the natural pacemaker of the heart, which actually generates the impulse. So all the heart impulse are generated from the SA nodes here, SA nodes. And then these impulses will travel. These impulses will travel. So where this sinoatrial node is is located, it is in the upper side of the right atrium, upper side of the right atrium, or kind of we say is appendage, appendage. So the appendage is the exact location for sinoatrial node. Appendage is the exact location for sinoatrial node, right? So in that case, this no this impulse will travel from sinoatrial node to through the wall or through the right atrium to the another node, which is again the atrioventricular node. Why we call it atrioventricular node? Because this is located between, I'm sorry, where is it? Yeah, so it is located between the atrium and ventricle. Between the, there is the just near to your valve, just near to your tricuspid valve, on the septum. It appears here, it's located here, here, atrioventricular node, AV node, right here. So the impulses which are generated from here through the internal nodal pathway, these impulses will go to the atrioventricular node, AV node here, and through the valve, it will go to the left atrium as well. These impulses, and these impulses will go to the other parts of the heart as well. But majorly system or the flow is like this. These impulses are generated from SA nodes and then going to AV node, and from the AV node, this AV node has the full conduction system, or the wires we call it. These impulses system will go through these main this connection. So this connection, this system, conduction system from AV node will go through the ventricular septal. See, as we can see, this is between the left and right ventricular, right? Left and right ventricular. So in the septum of left and right ventricular, these nodes, these node and system conduction system is located. And now, so these impulses from the SA node to AV node to, it will go to the different parts of the heart, different parts of the heart. How? From the AV node, it will go to the AV bundle. This is called atrioventricular bundle. This connects the atria to the ventricular, because see here, atria to the ventricular, and this connection, this part is the septum. So this is called atrioventricular bundle, and then from the atrioventricular bundle, it will go to the bundle branches. Bundle branches. See, these are the bundle branches. From here, it diverted. Na? From here, it distributed into two branches. One is going to right side, one is going to left side. Then these are the bundle branches. These two major bundle branches. After bundle branches, when it comes to the septum or endocardium. So in endocardium, these big branches or these bundles will again converted into different small kind of branches, very small branches, and they are combinedly called as Purkinje's fiber. Purkinje's fiber. So Purkinje's fiber is the we can say sum up of all the small uh, yeah, small fibers or small branches of the bundle branches or small branches of the AV bundle, right? Which are actually circulating or carrying the impulses, right? So impulses flow is like that only, it will go. So now what it does actually, the Purkinje's fibers actually depolarize the contractile cell of both the ventricles. Depolarization, right? Depolarization. What does the depolarization do? It will contract. It will contract the cells of both the ventricles, epithelium, and it will, when the heart muscles will contract, what will happen? The blood from these chambers will go out. Like when these muscles will contract, when these the depolarization happens, so blood from the left ventricular right ventricular will go to the pulmonary artery, and pulmonary artery to the lungs, and from the left ventricular it will go to the aorta, and from aorta it will go to the body parts, different body parts, right? So that's how this conduction system works. This conduction system works in the depolarization and repolarization of the heart, right guys? Depolarization and repolarization of the heart. So same thing is there from the SA nodes to AV node to subendocardial branches, and then branches to Purkinje's fibers, right? Purkinje's fibers, and these Purkinje's fibers are located in the septum and lateral valves of the ventricles. now now how does it work actually? How does it work? How does the this repolarization and depolarization work? It is very simple. It looks like very typical for you guys, because there are certain waves and different kind of things, but I'll make it very simple for you. Myocardial action potential curve. This is called myocardial action potential curve. It reflects the action potential, which describes the electrical activity of five phases. There are five phases in the electrical activity in the heart, right? And this occurs in the atrial and ventricular myocytes and Purkinje's fibers, because of course this system is starting from the AV node to branches, and from branches to Purkinje's fibers, and these Purkinje's fibers are located or distributed to the myocardium, right? So how does it start? Phase zero. See here, this this is called phase zero. This is very very rapid. It happens in the milliseconds when the impulse generated from the SA node it will come to the AV node, and it suddenly starts, and it start in the friction of the seconds, so it is very rapid, and suddenly reaches to that phase, reaches to causing the depolarization, suddenly rapidly causing the depolarization and reaching to the peak. As we can see here, phase zero. Phase zero is always called rapid depolarization. How? Now how to correlate? How to correlate this? Whenever the depolarization happens, sodium will enter into the cell. We know that contraction and relaxation, there are the two things. So contraction and relaxation depends on the what? Electrolytes, depends on the sodium, potassium, calcium, and chlorine, right? These are the four main electrolytes which balance the contraction and relaxation of the muscle, of any muscle. So this happens in the cell. So in the phase zero, suddenly rapid depolarization happens. So what will happen in that case? sodium will enter into the cell. Remember depolarization phase, sodium will enter into the cell, guys. Okay, and it will be sudden. Then again immediately the next phase starts. The next phase is a plateau phase, where it will start, like repolarization. Depolarization happened in the phase 0, but now it is the time to repolarize, or it is the time to start the relaxation phase, right? Repolarization. So in that repolarization, what will happen? In that, now potassium is inside the cell. So there are the many positive ions. So positive ions concentration is increasing inside the cell. So what will happen? Sodium will replace potassium, right? And then now sodium is in and sodium is coming in, so potassium will start leaving the cell. Potassium will go out in the phase 1. Phase 0, sodium was coming in. Phase 2, potassium is leaving out, just to balance the, a cellular matrix, or just to balance the electrolytes inside the cell, right? Then suddenly this phase, after 1 and 1, this phase 2 will start. Phase 1 and phase 2 actually both are plateau phase, but because as we can see here, phase 2 is for a longer time, and this goes around, for 10 to 30 milliseconds. 10 to 30 milliseconds, the plateau phase. So in that, what will happen? Sodium is already inside, calcium is going outside, leaving, and then suddenly calcium starts entering to the cell. Calcium has the bigger power, or the major power, because calcium is having two positive ions. Calcium is having two positive ions, where potassium and sodium has only one positive ions, right? Now when the calcium is coming in, suddenly again the concentration of positive ions will increase inside the cell, right? When it will increase, what will happen? Suddenly the phase 3 will start. Phase 3 will start, because now there are the huge positive ions inside your cell, inside your cardiac cell, inside your endocardium cell. So suddenly what will happen? Rapid repolarization will happen to make that balance, to balance the situation. Rapid repolarization. So what will happen? All the potassium will pump out from the cell. All the potassiums will pump out from the cell. Now from the phase 0 again will start rapid repolarization, sodium enters. Phase 1, early rapid repolarization starts, potassium will enter into the cell. Then plateau phase, calcium will enter into the into the cell. Now suddenly there is a oversaturation of the positive ions. Then suddenly, rapid repolarization will take place, not the plateau phase. Suddenly rapid repolarization will take place, like it will be happening from the 5 to 10 milliseconds. So all the potassium will pumped out to the cell. Now what will happen? Suddenly the cell cycle is complete. Now cell cycle is complete, contraction and relaxation is already done now. So what will happen? Then again that next phase will start, and it will take around 100 millisecond, around 100 milliseconds. And in that, simply again the potassium will start going inside. Potassium will go inside, and sodium and calcium will come outside. Then after 100 milliseconds, again that concentration of calcium and sodium in the outer region of the cell will increase, and then suddenly again the same phase, or again the same cycle will start. So I hope you understand it clearly. This is nothing much, but you have to remember the 5 phases: phase 0, 1, 2, 3, 4. 5 phases are not containing 5, it is starting from the 0. 0 is rapid depolarization. Depolarization means sodium. Early rapid repolarization means potassium is balancing the system. Then plateau, calcium is balancing, and calcium is going inside the cell. And then third, when this repolarization will be sudden, because positive ions are too much. The concentration of positive ions is huge inside the cell. So all the potassium will pump out from the cell. Then in phase 4, slow depolarization will start. Again the potassium will start going inside, and the calcium and sodium will come out. So I hope I'm clear here. So now I'll just show you the ECG wave, one ECG wave. So as we can see, the ECG wave has these simple parts. simple waves. It starts from the P wave. So P wave is showing us about the zero phase one, phase one, where rapid depolarization happens. you know Rapid depolarization happens. It will start from sorry yeah rapid depolarization. Then suddenly after P wave, why it is happening here. So why in case of hypernatremia P waves are affected, and why in case of potassium, this QRS complex is affected. QRS complex is affected because here it happens, rapid repolarization happens, and all the potassium goes out of the cell. So this happens, this is the rapid repolarization phase 4, right? So here at the P wave, rapid depolarization, phase 0, phase 2, and at the R, this will come to the plateau phase. This is the plateau phase, right? This is the plateau phase, and then sudden repolarization phase 4, right? Sudden repolarization phase 4, and then the again, it will start with the depolarization, and this gap is that 100 milliseconds. 100 milliseconds, again starting the new phase, again starting the new conduction phase of the heart. But there is a meaning, there is a different meaning of these waves. you know Different meaning what? When we come to the diseases, when it is showing, the P wave is showing early repolarization, or we can say the P wave is actually meant to associate with depolarization, but suddenly in some cases what happens, the repolarization is happening early. Repolarization is happening early, so it will cause arrhythmias, different kind of arrhythmias. Those arrhythmias are really dangerous. Those arrhythmias are called, early repolarization is called as W Wolf White Parkinson syndrome, something, WPW syndrome, right? WPW syndrome, right? And in case of atrial flutter or atrial fibrillation, guys, this P wave will not be there. This P wave will not be there because there will be no depolarization. There will be no depolarization in case of atrial fibrillation, when there is no the sodium is not coming out and potassium is not going out. In that case, usually this atrial fibrillation occurs, and in that case only this P wave will disappear completely. There will be no P wave in that case. So if you see any ECG without P wave, that means there is no, that this patient is having atrial fibrillation, right? And when it comes to the later phases, this ST segment is very important in MIs, myocardial infarction. In myocardial infarction, this normal, this is plateau phase, when ST segment is actually straight, actually straight at 180-degree. But in myocardial infarctions, what happens? ST depression occurs sometimes. ST depression occurs means what happens? This ST, it is like this, but it will go like this. It will go like this. It will inverse. It will go down, right? It will go down. So this is called ST depression. ST will depress to downside. ST depression, right? And if the T, which is we are looking, this has the Hell type shape right now. This has the upward situation right now. In case of lateral MIs, it will go down. This will inverse. So that condition is called T inversion, right? T inversion. So this is so now T inversion, right? So in that case, most probably a lateral wall and lateral wall MIs are occurring, which are including what we call it, LED involvement. Left ascending descending artery is involved in that cases, right? In T inversion cases, correct? So now what? Now there are the intervals. Let's talk about the intervals between P and R. Between P and R, this interval, or this a gap is called PR interval. Then the gap which is covering all the Q, R, and S wave, this is called QRS complex, because this is quite complex, because here sudden first your potassium will come out, and sodium will be going out. Then suddenly calcium will be going in, and immediately with the sudden repolarization, immediate repolarization, this situation will occur, this R wave will occur, right? So this is in a fraction of seconds. That's why it is very early, and I mean this is very quick, and that's why we call it QRS complex. And then ST segments, right? So after one wave, after one phase, or after one cycle, the next cycle will start again. So let's read about this. The electrical activity occurred during depolarization and repolarization transmitted through the electrodes. So ECG has, there are 12 lead ECGs, there are 3 lead ECGs, there are 4 lead ECGs, but standard is 12 lead ECGs. So those 12 leads are like 2 will be on your upper limbs, 2 will be on your lower limbs, 2 and 4 will be on your chest, right? 4 will be on your chest, and 4 will be on your abdominal region, right guys? I mean, not exactly abdominal region. 2 will be in the kind of between abdominal region and chest and that diaphragm. And if we say in the normal, like 6 will be on diaphragm, 2 will be on the stomach region, right? So what the P wave indicates? P wave indicates atrial depolarization, phase 0. Exactly, phase 0. PR interval indicates the spread of impulse. Then what is QRS complex indicates? QRS complex indicates the ventricular depolarization or atrial repolarization. Repolarization or ventricular depolarization. Right? Understand the difference here. What we were studying in the last, cycle in the plateau phase, we were reading QRS complex occurs in the phase 2 and phase 3. Phase 2 and phase 3 are what? Phase 3 and phase 3, phase 2 and phase 3 are related to repolarization and quick repolarization, but those were atrial repolarization. And the ventricular is totally opposite in that simple phase. In the same phase, ventriculars are opposite, totally opposite. So it will also called as ventricular depolarization or atrial repolarization, right? And then QT interval is actually the mechanical contraction of the ventricles. QT interval shows the mechanical contraction of the ventricles. And if there are the U wave, actually there are the till the T waves we actually we see in the ECGs, like here we can see in the ECG there are T waves, but sometimes the U wave appears here. U waves appear here. Why the U wave appears? Because when there is the less calcium levels inside the cell, and calcium is not started coming on the time, after the full phase is, again the slow depolarization will be there. So potassium will come in, but in that case, in the case when the patient is already having the less potassium in the body, patient is suffering with hypokalemia. So there will be less potassium which will go inside the cell, and which will induce the insufficient induce the conduction insufficiently, right? When the patient is already having the less potassium, so less potassium only will go inside the cell, and the phase, then there will be high concentration of the positive ions, of course, high concentration of the calcium and calcium and sodium. So that what will happen in that case? In that case, the mechanical concentration of the ventricles will affected, and U wave will appear, and that condition in total is called as torse at the point, TDP, torse at the point, right? QT prolongation is measure of delayed ventricular repolarization or atrial depolarization. Of course, when there is less we can say potassium, so of course this condition will appear in usually, you know. Okay, and these are talking about the torse at the points only. Okay, now there are few medicines which usually cause the QT prolongation, because these affect the potassium levels, or these affect the those what we said, the receptors which are helping the potassium to go inside the cell, right? Receptors or openings, or those are helping potassium to go inside the cells, right? But these medicines are doing opposite thing. They are stopping the potassium to go inside the cell. So that's why these QT prolongations are appearing, right? So the medicines include all the macrolides like clarithromycin, erythromycin, and then fluoroquinolones, gentamicin, or sorry, not gentamicin, like levofloxacin, all the floxacins, uh, getilofloxacin or moxifloxacin, gemifloxacin, or levofloxacin, right? And there are some antidepressants, and there are some antipsychotic drugs, and then quinidine, and your anesthesia drugs like procainamide, and then amiodarone is there, then methadone is there, and then ondansetron or domperidone. These all affect the potassium. uh, you know they affect they actually block the potassium channels in your cell, right? They affect the potassium channels, right? So then now we'll come to the ejection fraction. What is ejection fraction? Ejection fraction in a simple word is the pumping capacity of your heart. Pumping capacity of your heart. It again depends on the stroke volume. It depends on the stroke volume or diastolic and diastolic volume, and depends on the conduction system of the heart. So in case of heart failure, what will happen? In case of heart failure, your ejection fraction will be disturbed. Ejection fraction will come down. Ejection fraction will come down. In case of heart failure with reduced ejection fraction, or when the left ventricular is affected, when the left ventricle is affected, then only the ejection fraction will be affected. If the right atrium, or sorry, the left atrium is affected, in that case the patient is having diastolic dysfunction. In that case also, your ejection fraction will be similar. In that case, I mean, the ejection fraction will be normal. In case of diastolic dysfunction, in case of diastolic dysfunction, when the stroke volume is correct, stroke volume is correct, but the stroke capacity, the stroke capacity or stroke pressure is not proper or not normal. In that case, okay, so in that case, the ejection fraction will be normal, but there will be heart failure, right? So based on the ejection fraction, there are three types of heart failure. One is ejection fraction with no, I mean, where the ejection fraction is normal, so that is called heart failure with preserved ejection fraction. Preserved means normal ejection fraction, right? Ejection fraction is preserved normal. So in that case, your ejection fraction will be more than 50%, more than 50%. But when your ejection fraction is less than 50%, it will come down. So your pumping capacity is coming down. Your left ventricular is not working properly. Your left ventricular is not working properly. So this is the dysfunction. And again, this is categorized into two parts or two categories, like you know the low functions, like when it comes to 50 to 40, 50 to 40 percent of the ejection fraction. This is called mid-range ejection fraction. When it comes to the less than 40% of the ejection fraction, it is called heart failure with reduced ejection fraction, right? So again, there are three types of heart failure based on the ejection fraction. One is preserved ejection fraction, where your ejection fraction is more than 50%. This next is mid-range ejection fraction, heart failure with mid-range ejection fraction, where your ejection fraction is between 50 to 40, and less than 40% of your ejection fraction is coming under the heart failure with reduced ejection fraction. So what is the scene of ejection fraction? Let's know. Let it let's crack it. Ejection fraction is based on your stroke volume, based on your if we say, it is related to conduction itself. It is related to your relaxation and contraction, correct? So in that case, there are two types. As I'm talking about the diastolic dysfunction, in the diastolic dysfunctions, what will happen? Your ejection fraction will be same, but the size of the size of the ventricle size of the ventricle will reduce. Size of the ventricle will reduce due to the, maybe due to the cardiomegaly, due to maybe due to the cardiac cancers, or due to the myocardial infarction, or maybe due to the other problems, due to any drug. In that case, your cardiac conduction system will affected, and your cellular structure will be affected completely. Ejection fraction will be same. Ejection fraction is the pumping capacity, it will be same, but the size of the left ventricle will reduced. So what will happen, why we are calling it heart failure? The capacity of the ventricle to pump the blood will be same, but the amount of blood which is coming out from the left ventricle to the different parts of the body through the aorta, that will be less, that will be very less. Pumping capacity is not affected, but the amount of the blood is affected in case of diastolic dysfunction, right? So when the less blood will come out, less blood will reach to your body, less blood will reach to your brain, you will get hypoxia, you will get another problems, paralysis, and some other related problems like breathlessness, or in that case only you will get congestion and other symptoms, right? So that's why it is a failure of heart failure, it is a failure of heart, but in that case ejection fraction is normal. In case of reduced ejection fraction, what will happen, size of the left ventricle remains same, size of the left ventricle remains same, but the ejection fraction will reduce, but the frequency of that pumping will reduce, right? So in that case what will happen, blood amount will be sufficient, but it will not pumped completely, it will not pumped completely, it will be pumped partially, right guys? So in that case ejection fraction will be coming down. In that case ejection fraction is down because it's not sufficient, it's not pumping, or it's not throwing the sufficient blood from your left ventricular, right guys? So I hope you understand the difference between diastolic and systolic dysfunction. Now, what is cardiac output actually? Cardiac output is nothing but it is the multiplication of stroke volume and heart rate. And what are the factors which affects the heart rate? Of course, autonomic innervation, hormones, fitness levels, age. These things are affecting your heart rate. And the few factors which are affecting your stroke volume. Those are heart size, of course, fitness levels, gender, contractility, duration of the contraction, preload, EDV, we call it, and diastolic volume, and then afterload. So these everything sum up and make the cardiac output, right? Everything is called together cardiac output, right? So what are the preload and afterload? Just for the definition, volume of the blood fills in the ventricle in diastolic state. Afterload is the force to overcome the peripheral resistance, right? And there are drugs to control these preload and afterload, which are effective in your hypertension, like ACE inhibitors, ARBs, hydrogen and nitrates, because these are causing vasodilation, and due to vasodilation we come up or we overcome the peripheral resistance. Now let's read about the lymphatic system. So what is lymphatic system exactly? The lymphatic system is a network of tissues and organs that help rid the body of toxins. There are the toxins and waste materials and unwanted materials in your body. So a lymphatic system remove those things from your body. The primary function of lymphatic system is to transport the lymph to the different parts of the body, which makes it is kind of lubricant, and it collects all the unwanted parts, unwanted materials or wastes or toxins from the different parts of the body, and it will collect to the spleen or thymus, and it will excrete or destroy. So usually lymphatic system consists of tonsils in your as we get the tonsils, guys. So those tonsils are nothing but the imbalance or the problem of lymphatic system. And then adenoid gland, and the our lymph nodes, different lymph nodes are there at every system, and the full system lymph nodes are there, where the destruction and collection of the waste materials happens, or the toxins happens, right? And the major part of these the major part of lymphatic system, there are two glands, one is spleen and one is thoracic, one is thymus, right guys? Okay. Then what is the difference between blood and lymph? And there is something called interstitial fluid. Interstitial fluid is nothing but it is the lipid soluble substances which has a few, which actually provide the nutrients to the body parts, which provides the nutrients to the body parts. So let's talk about the plasma proteins. Plasma proteins are a lot in the blood, but plasma proteins are not in the lymph. That's why blood is carrying the nutrients. That's why blood is the carrier of nutrients, not the lymph. Lymph is the collector of waste materials. Like guys, lymph is the collector of waste materials, toxins, and foreign particles. But blood is the blood does actually many things, and one is the supplying of nutrients and supplying of oxygen to the different parts of the body. So plasma proteins are only present in the blood, but not in lymph and interstitial fluid. Fatty acids are presenting in all the systems, but majorly in the lymph, right? Hormones in all the systems, nutrients also again in the all the systems, and waste materials, of course, all the systems, as blood also have the WBCs, and platelets are only in the blood. Platelets are only in the blood. So that's why blood is responsible for the clots in your body, or for the stenosis, sorry, in your body. And then it comes to the WBCs, or the fighting cells. When it comes to the fighting cells, there are white blood cells, WBCs, right? So these are majorly, these are there in the lymph. Has the most Lymph has the most WBCs, because lymph has to fight with the foreign particles. Lymph has to fight with the unwanted bacterias and viruses sometimes. And blood also have the WBCs as well. Transports, what these transports? Blood actually transports the water soluble substances. Lymph transports the nutrient to cells and remove the waste. And interstitial fluid, mainly lipid soluble substances, are transferred by interstitial fluid, right guys? So blood, mainly water soluble substances. Lymph, nutrient to the cell and remove the waste. Interstitial fluid, lipid soluble substances. So let's uh, go with the question answer session for some time, guys. Let me ask. Yes, it is 8:30. I'm so sorry I was late today because of some problems, but yeah. Now let's take the questions, guys, right? And you have to answer the questions. Okay. Oh, I have a lot of questions for today. Okay, let's discuss all the questions, but first you have to answer my questions as well, right, guys? Hmm, okay. So it's not presented in the YouTube yet. Okay, so these are the, see, in the table, guys, you can see in the table there are the answers, and below the table there are the questions. So you have to pick the correct answer and fill in the blank. You have to pick the correct answer and fill in the blank. I'll make it full screen so you can see easily. I think you are able to see, guys. Yeah, I'll make it full screen. Mm, I think it's not possible in the computer. Wait, wait a minute. You think of the answers by the time, guys. Think of the answers, and I will immediately start that. What is the absence of rhythm? What is the absence of rhythm? Yeah, now I can make it full screen. Okay, so yeah, yes, guys. What is the absence of rhythm? Can you answer? Can you pick the correct answer from the arrhythmia? Okay. Now we are not unable to see. Now I think it's fine. It's full screen, right? Now you are able to see. So what is the correct answer? Arrhythmia. Drugs that causes positive inotropic effect. Positive inotropic effect. Can someone answer the positive inotropic effect? What's the drug? Positive inotropic effect, guys. 10. Digoxin. Of course, digoxin. Number 10 is always shows the positive inotropic effect. Rapid depolarization is the phase. Which phase is the rapid depolarization? Guys, rapid depolarization. Which phase is the rapid depolarization? Answer. Anyone from the chat box also, you can answer. Rapid depolarization answer, guys. Phase 0. Phase 0 is the rapid depolarization. Okay, phase 0. Okay, so what increases in the force of contraction? What increases the force of contraction? pH. Where is pH? Is there anything in the pH? Positive inotropes. Exactly. Positive inotropes increases the force of contraction. Number 8 is the right answer, right? Okay, the cell cannot respond to any stimuli. The condition is called as when the cell is not responding to any stimuli or cannot respond to any stimuli. What the condition called as? Yes, guys. The cell cannot respond to any stimuli. One, absolutely one. Absolute refractory period. Absolute refractory period. Okay. Then what is the cell ability to respond stimuli increases? Or cell can respond to strong stimuli? Of course, opposite. It is relative refractory period, right? And then what is the decrease in force of? I mean, what does the decrease in force of decrease in force of contraction? What is the right answer? Decrease in the force of contraction. What is the right answer, guys? Decrease in the force of contraction is by negative inotropic effects, or negative inotropic effect is called. So answer here for the second last is negative inotropic effect, right, guys? Negative inotropic effect. And then excessive negative charges in the cell occurs. Excessive negative charge. Excessive negative charge. Repolarization, right? Repolarization. Okay, so let's talk about the questions. I will just just make my screen simple, and let's talk about the questions in YouTube. Yes, guys. Now let me resolve the questions one by one. Oh my god, it's too much and I cannot see my questions as well now. ho. Where I can see my questions, guys. One sec. Oh, can you please retype your questions, because these went too much. Up. I'm not able to see the questions now. Can you please type the questions again here? Okay. So, what are the complications of tricuspid regurgitation, which is not discussed commonly as MR? Mitral regurgitation, of course. See, tricuspid regurgitation, or of course, MR is common, and AR is not that common, aortic regurgitation, because in that case, now what happens? This is not, kind of, we say as common as MR, because MR has okay. Can I leave, sir? Yes, of course, class is over. You can leave. Your attendance is already considered. Okay. So MR is very common. Why MR is very common? Because when the blood comes from the, your pulmonary veins to your left ventricle, and left ventricle is the most working chamber of your heart, most working chamber of your heart, because left ventricle has to push the blood from with the all forces to your body. And then in that case, mitral valve has that, mitral valve has that, what we say, the responsibility or working capacity. They have to show, the blood should not go back to the left atrium from the left ventricle. So in that case, what happens, this friction and, friction and the, force of the diastolic forces and the systolic forces, which actually push the blood from the chamber to the aorta. This is a big Herculean task. It's the Herculean task, right? For the left ventricular. So in that case, this is the Herculean task for the mitral valve also. And why it, get affected? Due to that force, due to that frictions. But one more thing is there, because when the blood comes from the lungs, it has foreign particles. It has many foreign particles. It has some, it is of course pure, but from the lungs, some particles are not filtered by your alveoli in the heart. Still this goes to the toxins, and all these directly go to your mitral valve only. So when it goes to the mitral valve is the place which is, directly catching up those things, and why mitral valve is affected? Because there are only two cusps, there are only two leaflets, right? And why it is happening? Because there are the high chances of stenosis in the left ventricular valve, right? So that's why MR is very common. And why AR is not discussed much, or tricuspid regurgitation is not discussed much, as you asked? Because it is actually nothing like that. It is not discussed much. It is discussed at a very, very high level. And now in the cardiology development, everything is coming up with the AVR only. AVR is aortic valve replacement. Those replacement usually, used to happen with the surgeries. But nowadays these AVRs are happening as easy as the angioplasties, right, guys? So but they are costly, of course. AVR, or we say the TAVR, trans aortic valve replacement, or saver, these things are there available in the market now for your aortic valve regurgitation, as a treatment. But these are very costly, like 15 lakhs, or more than 10 lakhs, or 22 lakhs, or 25 lakhs. These TAVRs are very much costly to the patients, very, very much costly to the patient. So in that case, you have to remember your the problem. And AR, why people are not discussing AR? Because there are not the appropriate medications, or there are no appropriate treatments, and patients are, but I will say you guys, uh, AR is more dangerous than MR. MR is not that dangerous. as MR. I mean, MR is not dangerous as AR, because AR treatment is not available, and whatever the treatments are available are very much costly, right? And what is the next question? Can you please describe the 12 lead ECG again? Of course, this C12 lead ECG is the standard ECG format. It observes the conduction from your whole body. It observes the conduction from your upper limbs. So the two leads will be placed on your upper limbs, upper arms, like upper limbs are arms, and two their ECG leads will be placed in your on your lower limbs, on your somewhere in the legs, somewhere in the legs. Then there'll be remaining eight eight leads will be placed on your thoracic and cardiothoracic area, or we can chest, or diaphragmatic area. And then I mean, out of those eight which are remaining, six will be placed in your chest and diaphragmatic area, and two will be placed on your stomach. So these 12 lead ECG will observe the conduction from whole body. So how it is reflecting your blood flow, how it is reflecting, not exactly blood flow, the conduction, but it happens with, because this our conduction system is related to your circulatory system. Of course, it is you know throwing the light through that, we can say the circulatory system as well. So in that, you have to check the velocity of the impulse, velocity of the impulse. You have to check everywhere from the body, every part of the body. So that's why we use 12 lead ECGs. But right now, we have 3 lead ECG also, and 4 lead ECG also in the market. So we just keep those ECG leads in your on your chest, and we just, because see, when MI occurs, when MI occurs, your impulses velocity changes on your chest itself. You can observe from the chest only. But 12 lead ECG will give you the 100% conduction abnormalities. Of course, ECG is not 100% sensitive. It is kind of 80 to 90% sensitive and specific, but it will give you the great idea about the problem, what is exactly and where is the exact problem. You will come to know about any arrhythmia. You will come to know about all the myocardial infarction systems, or myocardial type of infarctions, all the type of infarctions like ST elevation, or non ST elevation, or lateral entry, lateral wall infection, or anterior wall infarction, or posterior wall infarction. You will come to know about everything through the ECGs, that which wall of the heart is affected, which wall of the heart has the affected artery or infarcted artery. You will come to know about all the things. Yes. What happens if the ejection fraction increases? Increasing ejection fraction is always good. Um, in normal cases, increasing ejection fraction doesn't cause any problem, or doesn't cause any issues to the patient. Oh, NC. Okay, I'm so sorry. I asked about TR. Okay, you asked about the tricuspid regurgitation, not about the AR. Okay, yes. TR is not that common. Of course, TR is not as common as AR and MR, because TR. There. So first thing is, because left ventricle, sorry, right ventricular and right atrium does not have that much workload, as the left system has, or as both the left chambers of the heart have that the workload. So and again, there are three leaflets. Physically. If we check the physiologically, there are three leaflets. There are the and these three leaflets are very much strong than the bicuspid valve, bicuspid valves, or the two leaflets, or the you know if we say the two flaps. So three flaps are more strong, and these and here, see, when the blood comes from your body, it is collecting from the body, and it is coming from the right atrium to the right ventricular. It will directly flow to your uh, artery, pulmonary artery, and it will directly flow to your lung. So the pressure and that resistance is really less here, not that much. Yes, we have second exam on Sunday. Okay, someone is there asking about if TR is moderate with symptomatic dyspnea, then what is the treatment? In that case, diuretics are the treatment, and TR right now we do not go for the surgical treatments in case of TR, but of course we give diuretics, and we treat with the if there is something related to hypertension, or if there is something related to myocardial infarction, we treat the complications. In case of TR, we usually treat the complications, not exactly TR, because there is no not exactly the treatment, but we go for symptomatic relief with diuretics, and sometimes with ACE inhibitors. Yes. Okay, then conditions associated with T inversions. Myocardial infarction is the major condition with T inversion, and it usually happens when your left cardiac arteries or left LAD is involved, or left system of the heart is involved. So T waves inversion is usually associated with the left system or left myocardial left side of the arteries infarction. So whenever there are the T inversions, you can say based on the other waves also, not only T waves, but ST depression or T inversion. Based on that, you can say or what kind of impulse is there, that it is associated with the hypokalemia also. Hypokalemia is associated with T inversion, and the condition which is major is the MI. Okay. Okay. So, and okay, then what is this? Can you explain the systolic dysfunction and diastolic dysfunction difference again? Yes, systolic dysfunction and diastolic dysfunctions are, see, diastolic dysfunction is something when your heart chamber, your left ventricle size is decreased. Size, the amount of blood or the volume of blood is less, not the pumping capacity. In diastolic heart failure, in diastolic dysfunctions, the size of the you know left ventricle will decrease, and pumping capacity will be same, but the amount of blood which is thrown by the ventricular by the left ventricle to the aorta, it will be less, it will be insufficient, right? The amount of blood will be insufficient in any case, but here it is because the size of the left ventricular is less due to cardiomegaly, due to any kind of tumor, or due to myocardial infarction, or due to any kind of valvular problems, not exactly valvular problems, but due to any kind of arrhythmia also, not valvular problems, arrhythmia. So there are the four major components or four major diseases which actually affect that are myocardial infarction, cardiomegaly, or your arrhythmias, right? So in that case, your the wall of your left ventricle will be thick and will be thickening, and in that case the size of the left ventricle will come down. So amount of the blood inside the left ventricle will be less, insufficient. So if otherwise there is the what we say good if ejection fraction, good pumping capacity, but of course when blood amount is less, the blood will come out, it will be of course insufficient or less. But in case of systolic dysfunction, the cardiomegaly will not be there, the left ventricular wall will be same, the volume of the left ventricular will be, the volume of the blood inside the left ventricular will be exactly sufficient, but the capacity will be decreased, capacity of pumping capacity will be decreased, the ejection fraction will be decreased due to the conduction system, or maybe due to MI, or due to not cardiomegaly, due to some arrhythmias, right? So in that case, the pumping capacity will decrease, not the amount of the blood in left ventricular, right? But when pumping capacity will decrease, of course it will not be, able to pump the sufficient blood to aorta or to the body. The amount of blood which is going to aorta and to the body will be always less in both the conditions. But in the left ventricular, in the left ventricle, the amount of blood will be sufficient in case of left ventricular dysfunction. I mean, in systolic dysfunction, and in diastolic dysfunction, that amount will be less, amount of the blood. And in diastolic dysfunction, pumping capacity will be normal, but the volume of the blood will be less. So I hope I'm clear in that. I hope you understand. Yes, so heart blocks are, yes, exactly. I will definitely give a glance of heart blocks. Heart blocks are, normally there are few things. There are few things in heart blocks. Like one is conduction block and one is plaque. So plaque or the arterial blocks are different. Those are called heart attack, right? But when it comes to the conduction block, those are like first degree block or second degree block, or so these blocks are nothing but the damage of your the conduction system, damage of your Purkinje's fiber, or damage of your arterioventricular connection. So that damage will be there in that system, and your impulses will not be passed on to the complete part of the heart. Like if the left Purkinje's fiber is break has a break somewhere, it is broken by the myocardial infarction, due to some foreign particle, due to some drug, or maybe affected by virus or bacteria. If it is affected maybe by the inflammatory problems, then the conduction of that impulse, conduction of the impulse, or the velocity of the impulse will change. When the velocity of the impulse will change, or the that impulse will not pass on to the system, pass on to the next part of the heart. In that case, it is called conduction block, it's called heart block. So there are the degrees of heart blocks as well, like first degree heart block, second degree heart block, or complete left bundle branch block, LBB, complete right bundle branch blocks. So right bundle branch blocks are not much uh, problematic in case of the left bundle branch block. Why LBBs are why problematic? Because LBB, sorry, left bundle branches or Purkinje's fibers are going to your left ventricle. If left bundle branch block is happening, if the left bundle branches are blocked, or the conduction is blocked from the left side, definitely your left ventricle contraction will affect. It can cause heart failure, it can cause myocardial infarction, it can cause sudden cardiac death, right? So LBBs are most dangerous than RBBs are not that dangerous, right guys? Okay. How to identify the conduction system defect in heart? ECG is the only system to find out the conduction system defect in heart. And if it is not found in the ECG, then we go for rhythm studies that are for 24 hours or 48 hours. uh, okay, so what is TVD SVD in 2D echo? SVD 2 see, TVD and SVDs are not exactly seen in the echo. In the echo, we just see just see the mobility, or just see the mobility of the heart walls, not valves, walls. So wall abnormality can be seen in the echo. So based on that, we can just assume that there are two walls are affected, left side or right side, or there are the two regions are affected, apex region, or maybe anterior region or posterior region. So that is different thing. But from echo, you cannot define TVD or SVD. For the to define the TVD or SVD, or the vascular ventricular sorry, exactly the vessel disease, you have to go for coronary angiogram. Coronary angiogram only will give you the glance of your vessel diseases, how many vessels are involved. Okay. And then, yep, I think we are done. Okay, how does the VSD affect the liver? Yes, VSD is affecting the liver because uh, yeah, VSD and liver has the connection. Why these has the connection? Because liver and VSD is having that that supply of the oxygen, supply of that blood, blood and blood flow. It is connected because the that hepatic veins are the major veins where we need the pure oxygenated blood, in case of VSD your blood will be impure. It is not the direct connection, but it is indirect connection. When your blood, impure blood, will go to the liver, the liver will not be able to filter, or liver will not able to metabolize the your food, or metabolize your drugs, or it will not be able to metabolize the particles whatever are coming, fat and proteins, fat and proteins. So in that case your liver will be affected, and liver will be getting cirrhosis or some other conditions. Indirectly it is associated. Okay. Diastolic issue or ventricular size, how to identify? Echo is the only solution to identify the ventricular size. Yes, if you missed the first assessment exam, of course you can appear for the second, don't worry. Right, guys? Okay, so let's take off. Good night, guys. Take care. Bye bye. See you next week. Next week, I'm calling the very special guest, Dr. Krishna Undela from Naipur, Guwahati, for you guys. He will be taking your class on nitrates, Dr. Krishna Undela. So be alert, stay tuned. Thank you. Thank you, guys, for the listening.